Hello again. So this will be a talk on osteoporosis, and osteoporosis is not strictly really an endocrinological disorder. However, the major cause, in fact, of osteoporosis is decrease in estrogen levels, aging in women. So it kind of fits under endocrinology. So an overview of osteoporosis is that it's an extremely prevalent disease. Approximately 10 million people in the United States have osteoporosis. So what's that, about 3% roughly, 2%? An even higher percentage among the elderly. And an additional 34 million people have osteopenia. Osteoporosis is an underlooked, undertreated, and preventable disease. Therefore, there are guidelines that have to be followed as far as monitoring or detecting osteoporosis in a healthy patient. So we do actually do screenings for osteoporosis, and I'll talk about the screening guidelines towards the end. Primarily, osteoporosis occurs in white women that are over the age of 50, so your typical patient is the older, white, frail woman. However, it can occur in anyone. It can happen in children, it can happen in men, it can happen in blacks or Hispanics. It really doesn't matter. It's just the typical patient. The risk factors include being white and being over the age of 50. So what are the risk factors in all? Being more than 50 years old, that's a risk factor, regardless of your gender. The female gender is a risk factor. Being postmenopausal or having an early menopause is a risk factor. Those both imply lower estrogen levels. Another thing that is a risk factor is nulliparity, so never having had a child, a natural-born child. The white or Asian race is a risk factor for osteoporosis. Having thin build is a risk factor. Sedentary lifestyle, alcohol and tobacco use, hypogonadism, and hyperthyroidism. Those are two endocrinological disorders that can predispose to osteoporosis. There are drugs that can contribute to the development of osteoporosis, and those include most commonly the anti-epileptic drugs, particularly phenytoin, and corticosteroids. So in a question, you may have a patient that has lupus or has rheumatoid arthritis. Those are patients that tend to be on steroids. So that may be an opening to an osteoporosis question. The objective way we diagnose and measure the severity of osteoporosis is a T-score. And that's done by getting an exam, a radiological exam called DEXA, which is dual energy X-ray absorption. So what this is it's a bone density measurement. And the T-score is a number, and that number represents the standard deviations away from the average healthy adult in their 20s, the average bone density of a healthy adult in their 20s, which serves as our control. So if you're a negative T-score, it means you're less bone dense than the average healthy adult in their 20s. And if you're a positive T-score, then you're more dense. Now, with any patient who's older, they're generally going to be a negative T-score because in your 20s, you generally reach your highest bone density. So osteoporosis is defined as a T-score, which is a standard deviation, of negative 2.5 or less. So they're 2.5 standard deviations below the average healthy adult in their 20s. Osteopenia, on the other hand, is a low bone density, but it's not enough to qualify for osteoporosis. So it's between 1 and 2.5 standard deviations below the average healthy adult in their 20s. The average healthy adult in their 20s would be a T-score of what? It would be a T-score of 0 because they're the standard. So you're deviating from the standard. You're deviating below the standard. Now, osteomalacia is different. In osteoporosis and osteopenia, the bone matrix is intact. So you have two parts of your bone. You have calcium hydroxyapatite, which gives us the firmness of the bone, the hardness of the bone, and then you also have an organic matrix that the bone is surrounded by, that the calcium hydroxyapatite is surrounded by, and that's organic and it's primarily collagen. So in osteomalacia, what you have is a decreased mineral to collagen ratio. So in osteoporosis and in osteopenia, you have a decrease in your mineralization and a decrease in your organic matter, your collagen primarily. In osteomalacia, however, you just have a decrease in the mineralization. So osteomalacia is a totally different set of diseases. It's not related to osteoporosis and osteopenia. It's a disorder of bone mineralization only. The bone matrix, the collagen, is totally intact. So this is not related to osteoporosis and osteopenia. A lot of people get osteopenia and osteomalacia mixed up. But osteomalacia is solely a disorder of mineralization, of the calcium hydroxyapatite, whereas the organic matter is intact. With osteoporosis and osteopenia, it's both affecting the calcium hydroxyapatite and the organic matter, the collagen. Patients who have osteoporosis, the standard of treatment, the cornerstone of therapy that we use in most every patient with osteoporosis is the bisphosphonate class of drugs. Bisphosphonates include alendronate, risendronate, and so forth. Pretty much anything that ends in dronate, you can bet is a bisphosphonate. Okay, so what are the risk factors? We already talked about these, but let's talk about why these are risk factors. So in age greater than 50, as I sort of mentioned, you hit your peak bone mineralization, your peak bone density, I should say, your peak bone density at around your mid to late 20s. As an individual ages from there, the bone density naturally decreases. Being postmenopausal, having an early menopause, nulliparity, all of those things are associated with low estrogen levels. So estrogen, what it does is it induces the normal death, apoptosis, of osteoclasts. So if you have low estrogen, you're going to have less death of osteoclasts, so you're going to have more osteoclasts around. And remember, what osteoclasts do is they break down bones. So it favors osteoclasts over osteoblasts. Therefore, a low estrogen will increase bone turnover, and that's going to result in less bone in general. A thin build and a sedentary lifestyle. Why do those put you at risk for osteoporosis? Weight-bearing activities strengthen your bones. So living a sedentary lifestyle, not exercising, not walking, not doing a little bit of weightlifting every now and then, that will put you at risk for osteoporosis because strong muscles make strong bones. A thin build, it's really just the same thing. If you're heavier, you're constantly bearing weight because you have more weight because of your fat. So, sometimes it's joked, I'm not obese, I just have a low risk of osteoporosis. But indeed, obesity leads to a lot more problems than osteoporosis when you compare the two, but having a larger build puts you at less of a risk for osteoporosis. As far as some of the other risk factors of osteoporosis, the white and Asian ancestry, it tends to be that whites and Asians have lower sex hormone levels than blacks. So, and that's both for men and women. So black women tend to have higher estrogen levels, black men tend to have higher testosterone levels. And so having those higher estrogen levels for black women puts them at less of a risk for osteoporosis. However, it puts them at a higher risk for things that are put at higher risk with estrogen. So things like cervical cancer, ovarian cancer, breast cancer, endometrial cancer, and so forth. Okay, so then there are other causes of osteoporosis. Primary osteoporosis is just osteoporosis that develops. Secondary osteoporosis is linked to a specific cause, not a risk factor, but a cause. And a cause can be a drug, a disease, or a deficiency. Drugs would include, as I mentioned, anti-epileptic drugs and steroids primarily. A disease can be hyperthyroidism or hypogonadism. And deficiency can be a low calcium level, low calcium intake, or low vitamin D. And any of the things that can cause hypocalcemia, so renal disease and so forth. So screening for osteoporosis. Remember what I mentioned is that osteoporosis is an underdiagnosed disease. It's also extremely prevalent. When you put those two together, three things together: extremely prevalent, easily diagnosed, and severe complications. That means you should screen, because something that's very prevalent warrants being screened for, because a lot of people are going to have it. And if it's underdiagnosed, we need to do more to find it out before it leads to those severe complications. So remember that not all patients are going to have a clinical history or major risk factors. Nevertheless, they may still have osteoporosis. 67% of vertebral stress fractures are subclinical. So the United States Preventative Service Task Force, they recommend that all women, bar none, all women over the age of 65 get a DEXA scan. So that's our diagnostic, our best diagnostic step for osteoporosis. So all women over the age of 65 should get a DEXA scan at least once. As far as men and women under the age of 65, they should be screened based on clinical suspicion and risk factors. One of the things that will really tip you off towards osteoporosis is if a patient gets a vertebral fracture or a hip fracture after only minor trauma. So if you fall from 8 feet or fall off a ladder, that's one thing. But if you fall down one step, that's only minor trauma, and that puts you at suspicion for maybe this patient has a low bone density. Of course, having the other risk factors, being thin, having low physical activity, alcohol, smoking, having calcium deficiency, being on drugs like Dilantin, those are all things that increase your clinical suspicion because of risk factors. There are also various questionnaires, one being called FRAX, F-R-A-X, that you can give to any patient, and they can fill out this questionnaire, and you can decide whether or not you want to do a DEXA scan based on that. It's really based on your clinical judgment. But for the USMLE, you should know that all women over the age of 65 should get a DEXA scan. So the history in a patient with osteoporosis, sometimes they won't have any significant history. Sometimes you'll detect it based on routine DEXA scanning that you're supposed to do. White or Asian, as I mentioned, is a risk factor. A family history of osteoporosis or a family history of fractures from minor trauma is another thing that may come up in the history that's significant. Alcohol use, and when I say alcohol use, I mean significant alcohol use. The definition of alcohol use as far as being a risk factor for osteoporosis is greater than 3 quote-unquote units per day. And what a unit is would be a standard 8-ounce can of beer or a glass of wine, or 1.5 ounces of vodka. Being a smoker puts you at risk for osteoporosis, and use of anti-epileptic drugs or steroids. So in the case of steroids, look for a past medical history of rheumatoid arthritis, lupus, and so forth. The symptoms of osteoporosis are going to only be present if the patient actually has a fracture. Well, there are other symptoms. Thoracic kyphosis is another symptom. That's something you'd see in the physical there. Though, as far as what the patient would present with, though, if they actually came in to your clinic or into the ED, what they will usually have, if osteoporosis is the underlying reason, is vertebral pain related to a vertebral stress fracture, or hip pain, which would be related to a femoral neck fracture. Vertebral pain is generally point tenderness over whichever vertebrae is affected, and hip pain can radiate to the knee, groin, and buttocks. On physical exam, the patient with osteoporosis tends to have some level of thoracic kyphosis, which is kind of like a humpback that corresponds to the advanced state of their osteoporosis. So a patient who's got very minor osteoporosis may not have a very detectable kyphosis. The more advanced it becomes, the more severe it will become. A dowager's hump is a humpback. That's really just a severe kyphosis. Patients with osteoporosis, as that kyphosis advances, they will have a decrease in height. So you may notice that in an asymptomatic patient, as they come in each year for their annual physical, you may notice a decrease in height. Point tenderness is something that would point to a fracture, and gait instability is something that isn't necessarily associated with osteoporosis, but gait instability puts you at risk for a fall, and patients who have fractures often have risks for fall. So gait instability is something that might tell you that this patient could have had a fracture. If there are any signs of a fracture present, the best first step is not going to be to get your DEXA scan. It's actually going to be to get an X-ray of wherever you think the fracture is, because we're more concerned if there's a fracture about diagnosing and treating that. Then treating the osteoporosis, that can come later. But if there's a fracture, we need to address that first. Other causes of bone compensation besides osteoporosis include malignancy and, as mentioned, secondary osteoporosis, like hyperthyroidism, hypogonadism, steroid use, anti-epileptic drugs, and so forth. Labs, particularly calcium, should be normal in a patient with primary osteoporosis. So a patient who has low calcium, you may think possibly that this patient has had their parathyroids removed, and that can cause low calcium. Or perhaps this patient has a disease that causes hypocalcemia. So really you should get labs on a patient with osteoporosis just to look to see if this is primary osteoporosis or if this is secondary osteoporosis. Sometimes secondary osteoporosis can come from a malignancy, or sometimes a malignancy can infiltrate the bone and cause a fracture from that. So you need to get labs to sort that out. And so what are some of the labs you might get? So routine labs include a CBC and a CMP. CBC is normal in a patient with osteoporosis. Patients who have multiple myeloma, which is known to infiltrate the bone and put a patient at risk for fracture, those patients may have pancytopenia, so a low white blood cell, low platelets, and low hemoglobin. This would point towards multiple myeloma. The CMP should be normal or baseline in the patient with primary osteoporosis. So it should be either normal or no change from what they normally run. Low calcium levels indicate hypocalcemia, which can cause osteoporosis. If the patient has an increased BUN and increased creatinine, that indicates renal failure, and chronic kidney disease can actually cause bone mineralization disorder because of the fact that 25 hydroxyvitamin D gets converted to 125 dihydroxyvitamin D in the kidney, and if that doesn't happen, you're not going to be absorbing calcium, and so that can be the cause of your low calcium. So renal failure does put you at risk for secondary osteoporosis. Anytime the patient has a low calcium, you should be following that up with a parathyroid hormone level and a magnesium level. Remember that parathyroid hormone, if it's low, that's going to cause hypocalcemia. And the number one cause of elevated parathyroid hormone is the removal of thyroids and the lack of preservation of the parathyroids. Usually it's inadvertent. Magnesium level is important to have too, because magnesium level is necessary. A normal magnesium level is necessary for appropriate release of parathyroid hormone. And then, of course, it's good to get a 25 vitamin D level on any patient with a low calcium, because remember that appropriate vitamin D metabolism is necessary for calcium absorption. A high 25 vitamin D would indicate that the 25 hydroxyvitamin D is not getting converted into 125 dihydroxyvitamin D, and that would indicate possibly a renal cause. A liver panel is going to be good to have too. An elevated AST and ALT indicates hepatic disease, and that can be due, and often is due, to chronic alcoholism, which is a secondary cause of osteoporosis. A thyroid panel is useful to have. A low TSH with an elevated T4. I apologize. A high TSH with a... No, I'm sorry. I had that right. Never mind. I'm doubting myself. A low TSH with an elevated T4 indicates hyperthyroidism, which may cause osteoporosis. So if you have the low TSH, elevated T4, that indicates hyperthyroidism. That can cause osteoporosis. Other tests that you can get, I would always have these 4 tests. But you can get other tests based on the patient's specific history and risks. So if it's in a man, if it's in a younger man, you may be thinking, why on earth would this guy have osteoporosis? And one of the major causes of osteoporosis is hypogonadism. And a man doesn't have the traditional risk factors like being thin or amenorrhea or late menarche, early menopause. Those all happen in women. And alcohol and smoking alone shouldn't cause osteoporosis. So if a patient who's a man has osteoporosis or has signs of osteoporosis, you should really be thinking hypogonadism. So you should be getting testosterone levels and follicle-stimulating hormone levels on a man. In a woman, it may be good too, in a younger woman, to have that, because younger women, younger than the age of 50, they also shouldn't be getting osteoporosis. Remember, those risk factors are just to help you with older patients. With younger patients, you really start to think of some of the less common causes of osteoporosis. So hyperthyroidism or hypogonadism. Those are usually the causes in younger patients. Or, of course, the malignancy can be another cause, or parathyroid disease. Okay, so what is this thoracic kyphosis I'm talking about? And this is just that hunchback. So you can see here a normal woman, and this is a woman who has thoracic kyphosis. So basically what happens is it's a disease of the vertebral bodies of the spine, and you just get this sort of hunchback. This is a X-ray, of course, and what's important to remember is that thoracic kyphosis can cause decreased expansion of the lungs because you have less room in your thoracic cavity. And then this is just a look of what normal bone looks like compared to osteoporosis. This is a femoral neck fracture, a hip fracture. So you can see it here, and then you can see this one. It's a bit more severe. It's right here. This is a vertebral compression fracture right here. This line right here is compression, or compression fracture. And then here's another one right here. Okay, so if a patient has, if they have all the risk factors for osteoporosis, if they have risk factors for osteoporosis and there's no present signs of a fracture, or you've already worked them up for a fracture and you've treated it, the best first diagnostic step to confirm osteoporosis is going to be a DEXA scan. Remember, DEXA stands for what? Dual energy X-ray absorption. It's just an X-ray. That's all you're doing. It's a specialized x-ray, and it's read by a radiologist. Now, singularly, DEXA is the most accurate test. It's the first diagnostic step, the initial diagnostic step, and it's the most accurate diagnostic step. However, there is a questionnaire that the patient can do called the FRAX, and that's just a fracture risk assessment questionnaire. And when you have DEXA in addition to the FRAX questionnaire, that makes the diagnosis of osteoporosis even more accurate. But as far as diagnosing it clinically, we use the DEXA scan. And a DEXA of less than or negative 2.5 or more negative is diagnostic of osteoporosis. Okay, so how do we treat osteoporosis? Like I mentioned, the best initial treatment, the cornerstone of therapy in osteoporosis, is the bisphosphonate class of drugs. And there are a lot of them. Alendronate, which is marketed as Fosamax, Resendronate, which is marketed as Actonel. Those two are probably one of those two are probably the best to start with, and the reason is because of price. Alendronate and Resendronate can be taken every day, or it can be taken every week. And Resendronate, actually, there is a pill that you can take once a month. Zoledronic acid is another drug that can be used that's marketed as Reclast, and that also can be taken once a month. And then Ibandronate is a newer bisphosphonate, and this can be taken intramuscularly, and it can be done once a month. Now, one of the reasons that you may want to take it intramuscularly is because of some of the adverse effects of taking a bisphosphonate orally. And that includes esophagitis. And when I say esophagitis, I mean pill esophagitis, esophageal ulceration, and an increased risk of esophageal cancer. Not a seriously increased risk, but it's an increased risk enough to where the patient needs to know about it. So, but those only exist with the oral formulations of the bisphosphonates. So Ibandronate can be taken intramuscularly, and so you skirt by those side effects. But it is more expensive. And Ibandronate is Boniva, and you may remember that from the commercials. That's the one that's marketed by Sally Field. Some of the other causes, or some of the other side effects of bisphosphonates include bone pain and hypocalcemia, of course, because you're deactivating the osteoclasts. Selective estrogen receptor modulators can be good for women, particularly if they fail bisphosphonates. The selective estrogen receptor modulators are so that they are selective, so they don't cause some of the side effects that if you were to just take estrogen itself. So raloxifene is the most studied selective estrogen receptor modulator for osteoporosis, so it would probably be the best choice. However, there are a lot of different SERMs like tamoxifen; those can be used too. Raloxifene will not ameliorate vaginal dryness. It won't, but it also won't increase the risk of breast cancer or of uterine cancer, or endometrial cancer for that matter. There are, of course, selective estrogen receptor modulators are only for women. The treatment we use if a man is diagnosed with osteoporosis are the bisphosphonates, but SERMs are a choice in women. Generally, it's a second-line choice. Some of the novel therapies include the anti-RANKL antibodies, and what they do is they block a protein that's secreted by the osteoblasts that induce the creation of osteoclasts, or the maturation of osteoclasts. So this is a new drug, and the drug is called denosumab. Anything that ends with mab, by the way, is a monoclonal antibody. So it's an anti-some normal protein in the body antibody. So RANKL is that protein that it targets. This is marketed as Prolia. So like I said, it targets RANKL, which is a protein secreted by osteoblasts that stimulates the formation of osteoclasts, sort of maintains equality between osteoblasts and osteoclasts. This is a new drug. I wouldn't be too concerned about this for the USMLE. Just make sure you know about the bisphosphonates, the adverse effects of bisphosphonates, and the potential to use SERMs. Going back to the bisphosphonates, I want you to know that you should know when you prescribe a bisphosphonate, tell the patient that they need to take it with a full glass of water, and they need to be standing up or walking or doing something where they're not sitting down or laying down for more than a half an hour. Because if you're laying down, the pill might not get all the way down the esophagus, and that can cause esophagitis or esophageal ulceration, and that's obviously a bad thing. So they should be taking it at some point where they're able to take it with a full glass of water, and they can be up and at it for at least 30 minutes. Other treatments for osteoporosis include physical therapy to increase exercise, weight-bearing activity, occupational therapy to increase their function of activities of daily life, weight-bearing exercise, and calcium and vitamin D supplementation. Remember that the bisphosphonates are going to lower your serum calcium level because they decrease osteoclast activity, so it's important that patients with osteoporosis who are on bisphosphonates get good calcium and vitamin D supplementation.